Hi, welcome to Gorilla Implementation Science. This is CBT for OCD, a short review of the exposure response prevention models, some theories, and some protocols. If you don't know me, I'm Mike Morrow. I have a master's degree in clinical counseling psychology, a bachelor's degree in psychology, and I'm a cognitive behavioral therapist, both licensed addictions counselor and licensed professional counselor, and currently in a PhD program for counselor education and supervision. I also like to consider myself an advocate for evidence-based practice. So let's go. So what we're going to talk about today in this module is an overview of Intro to the Theory of OCD. What is OCD and its etiology, cause of, or at least what we believe to be true in the latest contemporary literature. And then an intro to the theory of exposure. So when we say exposure and response prevention, we really mean like the exposure therapy protocol for OCD. And then we'll do a little bit of an overview of protocol of exposure and response prevention. So what might it look like in session, or at least in the organization of a session? So OCD in the DSM-5, its diagnostic criteria includes the presence of obsessions and compulsions or both. So, obsessions are defined by unwanted thoughts that cause distress and or attempts at suppressing images or thoughts that cause distress. So, um, often thinking of something that is an unwanted thought, an intrusive thought, something that the person does not appreciate is kind of going on in their mind. And so they do one of two things. They'll have some action of anxiety or anxiousness about it, or they're trying to push it away, trying not to think about it. And then compulsions are repetitive behaviors or mental acts that are in response to an obsession, and the act is meant to prevent a dreaded outcome or an experience of anxiety without a realistic connection to the obsession or is clearly excessive. So, kind of breaking this down a little bit more, the obsession is some thinking mental pattern, and the compulsion is the attempt or the ritual to try to get rid of that obsession. So, if I have the thought, for instance, that my hands have germs on them, and so then therefore I'm going to kill someone else with my germs if I don't wash my hands until it feels right. The idea that I'm going to kill someone else might be the obsessive thought, and the compulsion is repeatedly washing my hands over and over again in order to reduce the harm I have towards other people. The issue is that um, washing hands multiple times doesn't actually reduce the chances of you getting someone else sick or anyone else sick. If it's sequentially in a row, there's no reason to believe that the third time you wash your hands is somehow more impactful than the first time you washed your hands. OCD etiology. So, what we believe causes OCD is the misinterpretation of some information. So, you're misinterpreting anxiety sensations, perhaps. So, some undesired anxious experience means a loss of control. I'm having my heart race, I'm feeling sweaty palms, or some other experience of sort of a somatic anxiety a sensation, and then all of a sudden I attribute that to like maybe a loss of control in some way, or that something, it's some sort of cue or omen that something bad is going to happen. Another misinterpretation that often happens is a thought action fusion bias. So the experience of a thought is identical to the experience of an action. If I think about it, if I think about harm to someone, I have caused harm to someone. Let me try that again a little bit slower. So if I think about harming a person, I see that as identical to having caused harm to them. So I think, oh, I'm going to light this person's house on fire is identical crime to actually lighting their house on fire, at least within the thought process and misinterpretation of an OCD presentation. I also may have an inflated responsibility. If I don't make sure I do something uh, right, I will hurt others. So if I have that thought, for instance, then I need to fix it, otherwise it's going to end up hurting other people. Or if I don't get the germs off my hands, it's going to hurt other people. Or if I am misbehaving in some religious way, it's going to hurt other people through mass catastrophe, through a deity's punishment towards the population. And so all of these things can come out through this inflated responsibility context or content. And so we think about that misinterpretation of thought fused action, inflated responsibility, and then even in misinterpreting the anxiety sensations, because we can have all three of these at the same time where the thought fused action bias creates a feeling of anxiety, and then I'm using that as confirmation bias. I'm only having the anxiety because I know I'm right. And another thing we can have is a threat overestimation, overestimating the actual likelihood of some incidents occurring. So I have this inflated responsibility that I need to take care of all these folks around me. I have a thought fused action bias, and where I think poorly, or I have a thought that shows some violent imagery to me, where I'm the perpetrator of that violence in some way, or even sexual violence at times. People can have like some intrusive thought about that and then believe they are a sexually violent person. And they have that thought fused action bias where they say, okay, I've had that thought, therefore I committed the sin or the act or the crime. And then it produces some level of anxiety. I have this level of anxiety, and now I'm misinterpreting that as some cue of maybe confirmation or actual danger. And then I'm overestimating how big that actual danger is going to be towards either myself or people around me. So another thing to link this to is schema. Remembering that schema is sort of like a core belief in cognitive behavioral therapy, sort of this abstract concept that a person carries around with them. And a schema becomes activated when it's in this when it's in time and when it's in context of time and space of a particular time and space. And so if I have a schema that says vulnerability to illness, right? If I have that, it may not be activated until maybe somebody coughs over my shoulder. Then all of a sudden I have these automatic thoughts that say, "Oh, I'm going to get sick. I'm going to get other people sick. It's going to be contagious. It's going to hurt me. It's going to kill me." These sorts of things. And so what we know to be true is that folks who are diagnosed with OCD tend to have predictable maladaptive schema. And these are three that stood out in one particular study here I've cited at the bottom. Vulnerability to illness, a belief that they're more vulnerable to illness than maybe the general population, dependence and incompetence schema, which is interesting. So the idea that they are more dependent on others and more incompetent than others in any particular part of life, which may suggest why overcompensation of details and perfectionism might make sense to offset the dependence and incompetence, and then pessimism, the pessimism schema of really seeing life through the lens of unlikely or undesired outcomes. That most things will be undesired outcomes. Um, so I think it's important to talk about these schema because if we're seeing a pattern in those cognitive beliefs, it might be helpful during cognitive behavioral therapy to address some of these schema and at least the attitudes at which they develop. Mental control. So a lot of folks with OCD may feel responsibility to control thoughts, or they fail to feel relief from other types of thought control, distraction or avoidance, right? So, meaning, so if I have OCD, I can feel some responsibility to control these thoughts that I have, especially if I think they're going to hurt other people. If I'm having intrusive sacrilegious thoughts, I don't want to have some deity punish the general population or punish people around me because I'm doing a poor job at maintaining my own religious righteousness. And so then, therefore, I have an inflated sense of responsibility, like we've said earlier, to control these thoughts. So it's really, really important that I start to control these thoughts. And that could be one avenue. Another could be I've also failed to feel relief from other types of thought control. So perhaps I'm worried that I'm going to get somebody else sick or I'm going to get sick. And maybe for the general population, when we have an intrusive thought, there might be something like a distraction or avoidance to not worry about it. So we don't engage in rumination, or we engage in a little bit of rumination and we go, okay, what can I do to distract myself? What can I do to not engage in this but avoid a little bit? So maybe some folks choose to drink. Maybe some folks choose to play video games. Maybe some folks choose to go exercise, go for a walk, do something like that. Um, what seems to be true with folks who experience OCD is that the distraction, avoidance, and other types of behaviors that the general population engages in, it tends to be less successful for folks with this diagnosis. So New types of thought control can be created to include both physical compulsions like hand washing or mental obsessions like counting some number internally, right? So, what we're looking at is, and maybe that should say mental compulsions as opposed to mental obsessions, but we're looking at physical compulsions or mental compulsions. That's a typo there. So, what we're talking about is some ritual that offsets this thinking and helps control the mind a little bit more. So if I hand wash 4 or 5 times till it feels just right, then all of a sudden I should be able to let go of that thought that I'm hooked by, that thought that says I'm going to kill someone else with my germs, with my attraction to germs, because I've done my due diligence. Now, as far as the mental compulsions on controlling things, it may be something like I say some religious prayer over and over and over again until it feels right, or ask forgiveness over and over and over again until it feels right, counting to some number, doing some of the more stereotypical rituals that we've heard of around OCD, in order to find what they're always looking for is this just right feeling. Or at least that's what a good chunk of folks who diagnose with OCD report having searched for, is a just right feeling. Often the compulsion acts as a method of thought control, resulting in some relief. And so that's the biggest thing, is these compulsions are seeking to have some relief to them, um, to the obsessive thinking. So this is where we come into Mauer's two-factor theory. If you've seen any of the other videos, you've seen me talk a little bit about Mauer's two-factor theory. That's because in most CBT anxiety treatments, Mauer's early theory is foundational to the reinforcement learning of safety behaviors and anxiety maintenance. So the basic concept, without going too deep into it, is that some trigger of anxiety happens. So something triggers a person to have anxiety, the avoidance of the trigger or the use of some safety behavior. Now, when we say safety behavior, we don't mean things that actually make you safe. We mean things that make you feel safe. So a safety behavior is not something that we try to encourage because it's often a um, a mechanism of relief that doesn't actually create any real change in safety. So the compulsions, for instance, are safety behavior. In substance use, we think of alcohol as a safety behavior, and in PTSD, we might think of a running out of a room that has cues on the TV, for instance, for some traumatic event. We would leaving the room. We would consider that a safety behavior. In phobia, running away from whatever you're phobic of, that would be a safety behavior. So then the concept is anything that's trying to reduce the anxiety but not actually reducing the safety is seen as a safety behavior. We see compulsions as this, so it reduces the undesired feelings. So going back, speaking more plainly, more simply, some trigger happens, the anxiety spikes, some safety behavior is incurred. You do some safety behavior to feel that way. And then because you do that, you learn that your avoidance or compulsion or whatever that behavior ends up being, you learn that that's the answer to the unwanted feelings. That's how you get rid of the undesired feelings. But then you end up in this feedback loop where you never actually disconfirm that anxiety trigger or remove that anxiety trigger. You're just in a circular motion with it. This causes a problem because some safety behaviors are deeply maladaptive, like compulsions. So if you're washing your hands 3 to 4 times, it can end up interfering with jobs. If you have to go back while you're on your way to work to go check, to return and check your locks again or check your stove again, that can also cause problems at work and disturbances with being able to function in your day-to-day life without spending excessive amounts of time rechecking things that you may be mostly sure of have already been taken care of. So what we are looking to do is removing the compulsions. When we remove a compulsion, a safety behavior, after purposely triggering a feeling, we call this exposure therapy. So that's really the in the most concise way to say it, we just take out the compulsions while we purposely trigger a feeling. So then that way we can see the reduction of whatever the undesired emotion is, but most of the time anxiety, a reduction of the anxiety over time. So in OCD, we refer to it more specifically as exposure and response prevention, or you'll often see it as the form of ERP, shortened to ERP. So response prevention refers to the idea that the person with OCD is engaging in a compulsion as a safety behavior versus avoiding a scenario as a safety behavior, as seen in other anxiety disorders. So, meaning, why are we calling it response prevention, like exposure and response prevention, where other exposures might be exposure to phobia or prolonged exposure for PTSD, things like that? Because interestingly unique in OCD that the response is the safety behavior, that there is some ritual attached. So we just want to do the exposure and then remove whatever that ritual is or whatever that compulsion is, and making sure we don't engage in that. So, title sort of self-descriptive in that way. Exposure therapy in the contemporary clinical landscape tends to be explained by two semi-competitive theories, which we'll go over next. So, first theory is emotional processing theory. This is sort of the classic theory. Memory structures for emotional content, called fear structures, are activated by some triggering event. So, what that means is we have some event that occurs that would trigger our fear. Now, let's say it's objectively safe to the general population, but we are interpreting that as having danger. It lights up our fear structures, lights up our sort of ideas of how to behave during a moment of fear. And then in order to correct this experience, the trigger must be experienced, and then new confirming information must be experienced. So, saying that more precisely, I if I feel like I'm going to get germs on somebody, or I'm going to die of some germ infection, right, or some other aspect of contamination, it may be that I need to touch a bathroom counter, then eat a slice of pizza. The goal in that would be that I would then expose myself to the trigger of having introduce the possibility of the germs killing me, but then I would receive disconfirming information when I realize, or when I eventually in the experiment and show that I did not have a mortal risk from eating a slice of pizza after touching a bathroom counter. Now, what this also helps with is um, lowering that fear over time, because I'm not doing the ritual either. Because for many folks with OCD, it's the ritual itself that helps the logic say, like, the reason I didn't die was because I did the ritual. Well, if we pull the ritual out, if we're not doing the ritual and we're just touching the bathroom counter and then eating the pizza, and we don't experience any sort of consequences from that, any significant consequences from that, then logically it has to mean that the ritual is not having an effect because I took it out. And this is what helps our body find this sort of disconfirming information, or our brain find this confirming information, which then results to and leads to overall a reduction in anxiety. So, what's important about emotional processing theory is, it, at least in the earlier versions, it really focused on what they called habituation, or the reduction of anxiety. So the concept was touch germy surface, eat food, don't get sick, anxiety gone. So basic idea of emotional processing theory is that we are eliminating anxiety. This is really important because in the contrary theory, inhibitory learning theory, um, associations of fear and anxiety as threatening are not helpful in the context of OCD. So that's how they're seeing it more so in this, is that when you associate your fear and anxiety as threatening, so not so much the trigger, but the fear and anxiety itself is threatening, that's not a helpful within the context of OCD. So what we are hoping to do is learn to tolerate and accept the experiences of anxiety, and which results in new learning and processing of anxious triggers. So when a trigger is present and anxiety is not experienced after exposure, inhibitory learning would suggest that a new competitive view of the trigger is activated instead of the old threat appraisal. Okay, let me say this in more plain language. So inhibitory learning is saying that you're not necessarily getting rid of the anxiety or habituating the anxiety. You're not like reducing it. Even if you feel a reduction in it, what you're doing is you're creating a competitive association with the trigger that says this trigger's safe, and it competes consistently with the trigger that it's not safe. And so at times you'll be using, the more you use the exposure, the more you're building up evidence that this association with this trigger is safe. So the summary here would be like touch germy surface, eat food, don't die. We might have some anxiety sometimes, but developing competing non-threat associations with each exposure. So you may still have anxiety the next time you touch a bathroom counter and eat pizza when you're not doing an exposure. And you have a lot of competing information that says it's okay to do this and it's okay to feel anxiety. So inhibitory learning theory slightly different in that aspect because it says it's okay to experience anxiety and it's okay to have it come back from time to time, but we still engage with our exposures and we still engage with life through a values-based lens. So, what does it mean? Theory versus theory. So, emotional processing theory is the classic theory. So, most RCTs use this theory around exposure and response prevention. When we see that exposure and response prevention has a lot of randomized control trials showing that it was is very effective for OCD. Well, pretty effective for OCD. There's some controversy around how effective, but ultimately, it's one of the most effective, at least, for OCD. And what's important in that is when they ran those trials, much of those trials were using the classic emotional processing theory. But inhibitory learning is a better explainer for relapses of anxiety. The a classic exposure therapy through emotional processing doesn't quite explain why do people relapse, why do people have anxiety come back for those same triggers. And so inhibitory learning tells us that's because we're not necessarily getting rid of the anxiety, we're not habituating to it, we're not going through an extinction process, but more so we're creating a competitive experience that has to be consistently engaged in to continuously make it stronger than that initial fear response. Both use the exposure method, and to be honest, I think when the mainstream clinician is engaging in exposure and response prevention, they're probably engaging in a little bit more emotional processing theory, but I don't know that it'll look wildly different if they were using inhibitory learning, other than a little bit of the methodology is a bit shifted and really subtle differences in the psychoeducation. So for instance, you may not need to do exposure until the person gets to zero. With inhibitory learning. Instead, you may just want to do exposure until the client sort of incorporates this idea that exposure is going to be a part of their life, that they're going to live an exposure and response prevention sort of lifestyle, which we'll talk a little bit about later. So, what is exposure and response prevention in detail, or at least in logistics? So, as with most cognitive behavioral therapies, exposure response prevention is often done in a very structured manner. What we would see is sessions 1 and 2. They would require treatment planning and psychoeducation on ERP. So, letting the client know what the theories are or what theory you're going to use, whether it's emotional processing or inhibitory learning. But ultimately, walking them through the logic of it, the rationale of it, and then talking a little bit about the basic concepts as they will engage. And then sessions 3 through 4, you're going to describe imaginal and in vivo exposure as well as begin to engage in the hierarchy of in vivo exposures. So um, you're you're going to actually do the exposures and sessions for both of these. So it may be in vivo exposure, maybe let's go to the, depending on where you're at and what you have access to, but hey, let's go to the restroom if the person, has the germ-based view of OCD. We'll go to the bathroom and we'll touch the countertop for whatever amount of time without engaging in a ritual. And then same thing with imaginal exposure, which we'll go over as well, but could be what's the worst case scenario that's going to happen and go through that. Intermediate sessions, five through who knows how many you want to do, up to, I don't know, 20, focusing on continuing the hierarchy, doing various hierarchical exposures. and then a termination and graduation phase. And in that, you'd want to work on relapse prevention or at least coping skills to manage relapses as they occur. So before we get into that, we got to talk about the subjective unit of stress. So subjective unit of stress is a common unit inside of exposure therapies generally, and it's a way to communicate distress of any particular experience. So it often ranges from 0 to 100, where 0 is the most relaxed or non-distressed a person can be, and 100 is the most distressed a person can feel. So a client would record their SUDS during exposure tasks to mark their progress. We would expect to see SUD scores lower over time with more exposures. So the thing about SUDS is it's relative to the person, not so much between clients. So you're going to be thinking about, okay, where do they start on this exposure? And where are we ending on this exposure can be a really helpful tool to say, like, okay, that was 100 3 weeks ago, and now we're down to a 75, 60, 50. Um, the other thing that's interesting about SUDS is it can help you build out hierarchies of which exposure is the most challenging because they can self-rate what SUDS they experience in each exposure so you know which ones are more difficult for them and which ones are less difficult for them. What does the in-session structure look like? Well, once the psychoeducation and treatment planning are done, in-session exposures are accomplished. So, a common agenda could be 5 to 10 minutes of a check-in on homework, 30 to 40 minutes of exposure practice, either imaginal, in vivo, or maybe even a combination of both. And then you may do 10 to 20 minutes of processing or cognitive therapy. So that could look like Socratic questioning, sort of trying to get at some of those schema that we talked about earlier, or even some of that misinterpretation of over responsibility, things like that, in order to try to soften or dilute the conviction they have around some of the maladaptive schema and automatic thinking and misinterpretations. And then maybe you spend 5 or 10 minutes for homework assignment for the next session, which could be more in vivo exposures as they go back out into the world for the between sessions. So the agenda and emphasis may be modified based on clinical relevance. You, as the clinician, I would expect you to really use your judgment and what makes sense and how to pace the content. I would also say I would not modify it in a way that reinforces avoidance, only modifying it in a way that makes exposures more likely and collaborative. I think that's a really big important piece is that all exposure therapy, no matter what type it is, should be collaborative in nature, especially since it can be so distressing. The client should have autonomy and should enthusiastically want to engage in exposure, at least intellectually. Maybe not in the moment, but at least intellectually as they start the process. So here's some common techniques for OCD especially within CBT is you'll definitely use psychoeducation. You'll be teaching about the overview of OCD, but the overview of exposure, the different theories, why exposure and response prevention is helpful, some of the research on it to say that it is effective and we're using the most efficacious treatment we can for this particular problem. Uh, you will also be using in vivo exposures, imaginal exposure, Socratic questioning. So we'll go over each of these individually. So, psychoeducation. You could be describing exposure therapy theory, discussing the process and the rationale, discussing goals, talk about the evidence base, and encourage grit and commitment. I can't stress that one enough. Is that you really want to reinforce finishing the exposures if we're starting because I think you it would be unhelpful to start an exposure but then sort of support the avoidance afterwards because the entire point of the exposure is to gain that disconfirming information and in the inhibitory learning sense, create new competitive pathways. But if we're reinforcing the avoidance, we're now making that association with the trigger stronger and participating in it ourselves. And so that may be something that we'd want to really pay attention to so we don't overly emphasize avoidance or support avoidance. In vivo exposure, we're going to, in vivo, of course, Latin for in life. So we're going to build a hierarchy. What that means is we're going to think about different exposures and we're going to put them in a hierarchy in which the client will engage in each exposure exercise and gradually move themselves up to the harder and harder exposures. So I have a picture here of a young woman holding a gas pump. Well, the reason I bring that up is um, sometimes if you have a germ, a germ concern, it could be that you don't want to touch a gas pump. You don't want to be around a gas pump. You don't want to feel it because so many other people have touched it. And so that could be one of our exposures. Um, but we want to engage with that feared stimuli for a timed minimum. So you do not want to exit it prior to whatever commitment that's been made for a particular set of time. Earlier exposure therapy concepts may be, well, let's do it until the SUD's reduced. That could be impractical because it could be hours before the SUD's reduced, or it could be minutes. Also, it kind of gives some avoidant clients an incentive to rate their SUDs lower in order to end the exercise. So it may make more sense to set a time limit, and then we can all agree on an objective start-stop point. Um, we also do not want to engage in a compulsion or other safety behavior during it. So, really encouraging and coaching the client not to do a mental compulsion, um, such as counting, praying, something in that aspect to keep them safe. And then simultaneously, we also don't want them to engage in any other safety behavior outside of that. So, we don't want to be using anti-anxiety medication that is narcotic based, for instance, or we don't want to engage in closing their eyes or trying to wince and not think about it. We want to be fully engrossed into the in vivo exposure. This would be done both in session and as homework. So anything we can do in session, we'll do in session, but then simultaneously we would encourage it by themselves. This gives us a diversity of experiences, which tends to help exposure more generally because you have more data sets and experiences to draw from when either habituating or doing the inhibitory learning of creating a new pathway. Here's what the exposure sheets would look like. I got this out of the Cognitive Behavioral Therapy for OCD and its Subtypes by David A. Clark. So each exposure worksheet. So first, you on the left here, you'll build an exposure hierarchy with the client, and they can rate their difficulty level, how difficult they believe it to be. And then this way you can kind of look at and start to order the exposures in some rank. And then as the exposure worksheet, we can then go in and do an exposure, rate our initial discomfort, our final discomfort, and however long we were in the exposure. What's interesting, there's a couple of things that are interesting. Most exposure therapy puts us in a hierarchy where we start from the bottom to the top. I've read a couple of different research articles that talk about ways to do this, but one thing that was interesting was if you randomize the exposures, it seemed to, at least in one study, have a high effect and a high efficacy for exposure. So I say that to say the randomization might be a really interesting thing, but it also might be a hard sell. So I say that more of an interesting story than saying that is protocol. So in this, we got the one, two, and three. So for by David A. Clark says, start with the one. What is the exposure we're going to do? How are we going to do it? And what do I need not to do? Then they do the homework, and then when they come before they come back, they sort of reflect on what happened and bring that back to session. So it could be a really good way to engage in an exposure homework. Imaginal exposure. Imaginal exposure is exposure that includes exposure to a feared outcome through the imagination. So when we say imaginal, it's really a cognitive exposure. It's anything that your mental faculties can produce. You're exposing yourself to that. So it may be to an obsessional thought without the compulsion attached, some avoided cue, such as a sacrilegious statement or content, It's really any place that you, as somebody who's diagnosed with OCD, if they're not allowed to go somewhere in their mind, the exposure itself would be then to go to that place. So here's an interesting one that you can try for yourself to see if this makes you feel uncomfortable. Read this sentence out loud. I hope I left my stove on. I hope my kitchen is currently on fire. Now, if you have a little bit of anxiousness from saying that, I don't know that that automatically means that you have OCD, but maybe you have some a fear of saying a sentence out loud. Then it gives us a tiny little bit of an insight into what it would be like to experience the exposure of true and clinically diagnosed OCD. Another intervention could be Socratic questioning. So, common CBT techniques used to change perspective through various styles of questioning, often used to elicit client rationale and guide the client to discover discrepancies and maladaptive beliefs. Socratic questions can be aimed at challenging beliefs that are unhelpful. So, it's a very old technique in cognitive therapy, maybe one of the first. It's really sort of an educational tool, and so that's why it's used to sort of elicit a perspective change. Do you believe your coworkers think about their stove as often as you do? Why or why not? A question like that could help us elicit whether or not they're seeing themselves relative to the people around them. Many times, knowing that that other people aren't thinking like you can be helpful because then it can help undermine your own conviction that this is the right way to think or that this is the appropriate way to think or everybody does this. It can help really undermine that conviction, leading to some perspective change for some folks. So Socratic questioning is a foundational and really important tool in cognitive therapy. So, what would termination look like? So, we get through the interventions and we do the different techniques, and we're getting to a point where the client is engaging in exposures spontaneously and on their own, and they are seeing less and less suds as they're engaging in these sorts of uh, ways of seeing the world and opening up their life. So, in the completion of ERP, we should help the client plan for the following. We would expect relapses. In OCD, we're not going to pretend like it's not going to happen. Instead, we're really trying to say anxiety can come back on these triggers, but anxiety is not our enemy. It is not something we run from. It's something that we experience, we accept, and we sort of move through. We would try to adopt an ERP lifestyle where exposures are engaged in naturally without response as a way of being. That's your way of being. You now uh, almost welcome anxiety as it relates to the OCD. Okay, here's another opportunity. Here's another chance for me to practice the skills I've put together. I am so grateful at times to have had this experience of vigilance as my mind, body, soul wants to warn me of some danger, and I'm here to reassure we're going to be okay. We're going to keep moving forward. We also want to confront many rituals. We don't want to let the small rituals start to build into big rituals. There's not, we want to treat it almost like you would treat addiction of some sort, which is no small permissions, none of these smaller things that would otherwise allow for or give us an ability to start snowballing these rituals back into some regular routine. We could also schedule booster sessions a few weeks or months out if needed, thinking back to this idea that we're going to probably expect some sort of relapse or some sort of anxiety resurgence. So come back, let's talk it out, let's keep on a path and think through our ability to maintain, again, this ERP lifestyle. Here's some useful books that I would suggest if anybody's interested in learning more about exposure and response prevention. I would also suggest getting formal training, as it can sometimes be difficult to do exposure therapies generally without some sort of training. But these two books are great: Cognitive Behavioral Therapy for OCD and its subtypes, and then Exposure and Response Prevention for Obsessive Compulsive Disorder. I'd say David A. Clarke's book is really theory heavy, very theory heavy in a good way, meaning that it'll kind of give you some of the background, some of the up to date data on etiology and prevalence, where the treatment manual is going to give you step-by-step instructions on exactly what they would do in a randomized control trial, which can be very helpful in knowing um, how far away you are from fidelity or how close you are to fidelity, meaning how much are you matching what the RCTs were doing. So a great combination of books together. Um, Thank you for your time on watching this. And if you liked it, feel free to subscribe. Also, feel free to hit me up with any questions in the comments and we can talk things out.